Hi everyone, my name is Dua Abdalal. I'm a program support manager and I work in the NHS Cancer Programme in the Operation Performance team. And welcome to the Cancer MDT Improvement Programme. So this is our first session, and we're doing this project in collaboration with the Elective Care Improvement Support team. So we've got a few of the team on the call with us. We've got Robin Cupforth, Alison Poole, Matt Noonan, and Crystal Skinner. So first of all, we're just going to go through the agenda and on our list today. So we've got a little bit of introduction from Professor Peter Johnson, and then we're going to give you all a minute to introduce yourselves and tell us about your teams. Then we're going to hand over to Ben Lamb to talk us through challenges with MD2 improvement. And after that, Robin and Alison are going to talk to us about the program itself and the outputs. And then we've got the QI team from Great Ormond Street coming along as well to talk to you about QI methodologies. And Alex Graham is going to come along to talk to you about evaluation. Next slide, please. So before we start, just some ground rules and expectations. So where possible, really great if you could have your cameras on because we're expecting everyone to, discuss and it'd be nice to actually see everyone. Please do mute when you aren't speaking. And yeah, like I said, it'd be great for everyone to actively participate. Please do feel free to use the chat box as well. Feel free to, put your hands up if you want to ask any questions and get to know each other. And yeah, there's space for some active listening. Please do give full attention to the speakers and try and acknowledge contributions from others. As I said before, please do feel free to use the chat function. So you can ask questions, provide links, share insights. You can talk to the rest of the team through there as well. And yes, stay open-minded, be receptive to different perspectives and approaches from other participants. So next, we've got Professor Peter Johnson, the National Clinical Director for Cancer, who's going to introduce the session to you guys.
Thanks very much, Dua, and great to see so many people on a grey Friday afternoon joining to talk about MDT improvement. And thank you all very much for signing up for this programme. Everybody on this call will be very, very familiar with cancer multidisciplinary teams and the meetings that they run. These have become an absolutely established part of the landscape of cancer care over the last 10, 15 years. Having said which, I think we all recognise that they are quite variable. Some are good, some are not so good, some are efficient, some feel very cumbersome. And I think all of us feel slightly burdened sometimes, and particularly colleagues from radiology and histopathology sometimes with the process. I'm a medical oncologist myself, so I have a great time in MDTs, but I know that colleagues from diagnostic specialties sometimes find them really quite onerous, and many of them are attending many a week. So I think it always is important to take a careful look at what we're doing and see if it can be done better. And I think many of us spend so many hours each week doing the day job, looking after people, attending the MDTs, getting ready for them, that we don't always have time to take a step back and think, well, are there better ways of doing this? Can we streamline what we're doing? And can we make better use of all the time of the people in the room? And certainly I go out and about and visit different services as part of my job. And I'm often struck by the sheer size and the number of people in a room in MDT meetings. Quite often, some of them having quite a quiet time, and making sure that everybody can contribute and everybody adds value to the meeting is quite an ask sometimes. I think as part of the National Cancer Plan, which we're in the process of writing at the moment, I think we're acutely aware that there's probably room for renewal and improvement in the way we run MDTs, and there's more to come on that in due course. But even now, even where we are now, I think there are lots of things we can do. We published some guidance back in 2019 about streamlining and taking cases that didn't need to be routinely discussed out of the MDT and streamlining decision-making process. It's very clear that the pickup of that guidance has been very patchy indeed, and that really underlines my starting point, which is that we all do things a bit differently. The great thing is we can all learn from each other as a result of that, and I think there's always a way to do things better. I get a lot of value and stimulation and interest out of my weekly MDT meeting, which we run down on the South Coast, working with about 6 different cancer units, all dialing in turn to the meeting but there's no doubt that the amount of work that gets done and the speed with which the discussions take place is a continuous challenge. So I think it's great that people have managed to carve out a bit of time in their very busy weeks to come together to think about how we do things, what's good, what's not so good, and to think about how we can do things better. And as I say, how we can make the best possible use of our time so that we deliver the best possible service to the people we're trying to look after and make sure that they get the right decisions and the right access to treatment as rapidly as possible. So with that, I will hand back to Dua and let you all get on with the process of introducing yourselves to each other.
Brilliant. Thank you so much, Peter. So, as Peter said, we're going to do some entity introductions now. So, each team will have 1 minute to introduce themselves to everyone on the call, and we do have a timer. So, you'll be able to see like a little ball moving across the screen next to the slide to time you. So, could each team please nominate one person from your team to lead and let us know what MDT you represent and one thing you'd like to learn from the programme? And the first team we have on our list are County Durham and Darlington. Anyone from County Durham and Darlington on the call?
Yes,
Yeah,
sorry,
go ahead.
I'm here, but I know that our lead clinician's here as well. So I don't want to put you on the spot, Richard. But would you like to do the? I'm quite happy to do what you might prefer to.
Yeah, sure. Hi everyone. Thanks, Denise. My name is Richard Chalmers. I'm a consultant head and neck plastic surgeon at Durham Hospital. I've been the MDT lead for about 6 years, pretty much, I think, the second week within the job. I'm also the skin lead for the Northern Cancer Alliance as well. Really interested in streamlining and improving MDT efficiency, so that's why we're here.
Great, thank you so much. And next up we have Guy's and St. Thomas's.
Hi, my name is Wen. I'm a consultant pathologist from St. Thomas Hospital. Not sure whether anyone else is from my team, either on the surgical side or oncology. But
Hello, I'm sorry I don't have. And
Georgina.
I am sorry I don't have a. Yes, can you hear me?
Yes,
Can you
we
hear
can
me?
hear you. Yes, we
Hello?
can. Hi.
Hello.
Oh, I think you're cutting out a bit.
But I'm also here. I'm one of the MDT coordinators at Guy's and St. Thomas's.
Wonderful. Nice to meet you. And next up we have Nobles Hospital. Oh, sorry. Next up we have King's College Hospital.
Hi, I'm Laura. I'm the cancer improvement leader, cancer performance lead at King's. We are here for the hepatobiliary HPB MDT. So big regional HPB service at King's, big tertiary centre, receiving referrals from all over sort of the southeast. So yeah, very big specialist MDT and keen to explore ideas about how we can make it more efficient. Thank you.
Great, thank you so much. And next up we have Nobles Hospital from the Isle of Man.
I'm Stella. I am one of the colorectal and general surgeons. We're representing our colorectal MDT. With me, I have Carol, who's our CNS, Verity, and Violetta, who are our MDT coordinators, and we've got our MDT manager, who is Violetta. And online, we have Verity, who is our data officer. Unfortunately, because of the storm, our pathologists and radiologists couldn't make it. We are on the Isle of Man, so we are slightly siloed. And what we want to learn is how we can adopt innovations that are being used in other entities to improve our MDT, because we're always looking to make improvements.
Wonderful. It's really nice to see you all in person as well. And next up we have Mersey and West Lancashire Teaching Hospitals.
Hi everyone, my name is Mo Abdul Majid. I'm a consultant urologist. This is our new trust name, merger between two trusts 2 years ago. That includes Western St Helens and Southport and Ormskirk, based in Liverpool. And we run obviously weekly MDT on both sites. We're trying to merge into one, so that's really one of the factors that led that we sign up to this meeting. I have my colleagues as also and nurse colleagues as well signed up, and Nancy is one of our CNSs on the link as well.
Brilliant, lovely to meet you.
Thank you.
And next up we have Salisbury.
Hi there, my name's Tara. I am obviously calling from Salisbury and I'm the Deputy Cancer Services Manager. I don't think anyone was able to attend this meeting apart from myself, so apologies for that. But we're obviously looking at trying to streamline our urology MDT meetings and also our lung MDT meetings. They both have very different issues linked to them. Urology has got absolutely huge over the past couple of years, and we're trying to and make it work more efficiently, and it's the same with lung. We want to make it more efficient, but we're just trying to work out best practice for those.
Great, thank you, nice to meet you. And we have Tameside and Glossop Integrated Care.
Good afternoon, everyone. My name's Anthony Edwards. I'm the Deputy Divisional Director for Surgery here at Tameside and Glossop, which is a medium-sized DGH up in Greater Manchester. Also on the call this afternoon, we've got Mr. Pardeep Arora, who's our breast specialty lead, along with Natalie Heath, who's our Deputy Cancer Manager, along with Nicola Barker, who's one of our MDT coordinators. As I probably just alluded to in the clue in terms of Pardeep's role, we're looking at this from a breast MDT perspective. And again, very similar themes to a lot of other colleagues on the call. We're looking here to look at best practice. We've gone through some significant changes recently in our breast MDT approach, and we want to look at what are the best practices out there, and then from myself and Natalie's perspective on how we can drive that quality agenda right through our other MDTs across our all other tumour groups. So looking forward to working with you all. Thank you.
Lovely, nice to meet you. Thank you. And next up we have University Hospitals Coventry and Warwickshire.
Hi there, my name is Sabur Khan. I'm one of the hepatobiliary pancreatic surgeons. I am a member of the HPB and lead for the NET team. I think the challenge here is that we have the quality of information going into the MDT, the presence of the right people and talking either sequentially or together to answer the questions asked. And that's forever a challenge for us. We're trying to improve and we have made some innovations, but I am really looking forward to learn.
Great, thank you for sharing. Nice to meet you as well. And next up we have University Hospitals Plymouth.
Hi everyone, I'm Amla, Cancer Improvement Manager at University Hospitals Plymouth. My main focus is on MDT streamlining, and at the moment I'm working on urology MDT as a part of this program. Yeah, thank you.
Lovely, nice to meet you. Thank you.
Nice to meet you as well.
And next up we have West Suffolk.
Hello, I think I'm going to introduce us today, if that's okay. I'm Robin, I'm from West Suffolk, and I'm the Cancer Transformation Lead within the Trust. We're bringing our gynae team to this event and forum to learn more about how to streamline the MDT. We've done the evaluation, and I don't think we're actually in too bad a shape, but it's always good to learn more and make the improvements as we need. So I don't know if you want to add anything, Malini?
No, thank you so much, Robin.
Thank you.
Fab, thanks team, nice to meet you. And next up we have North Cumbria Integrated Care. Do we have anyone from the Trust?
Hi, I'm Chris Rao. I'm a colorectal surgeon in Cumbria. Despite what my badge says, I'm no longer based in Frimley. We have a really busy colorectal MDT here. It's becoming increasingly more busy, and the patients are becoming more complex because of the multimodal way that we treat rectal cancer now, and also because of patient comorbidities. So we're keen to learn how we can streamline and make our MDT as efficient as possible. So thank you very much for this opportunity.
All right, lovely to meet you. And last but not least, we've got University Hospitals of Leicester.
Thanks. I thought you might have forgotten us. I'm Baljet. I'm the chair for the colorectal MDT. I think the challenges are time commitment. This afternoon we've got other meetings, so some of my colleagues haven't been able to join. What do we want to get out of this? I think sort of efficiency, to be effective, and also see MDT as a learning opportunity, try and get people into research, get our CNSs involved and the rest of the team, particularly the junior grades, to be involved as well. So it's more of a learning and educational and enjoyable afternoon rather than a sort of a long afternoon where we're just going through numbers, really. Thanks.
Brilliant, thank you. Well, it's really lovely to meet you all and great to have representation of everyone here. So next up on the agenda, we've got Ben Lam coming on to speak about challenges with MDT improvement, and Ben has done a lot of amazing. Oh, sorry, Georgina, you had your hand up.
Apologies. I don't know if you can hear me now.
Yes, we can hear you.
I just feel it was very rude for me not having introduced myself. I'm on study leave at breast conference, and the internet is really bad. I'm Georgina Mitiago. I'm a consultant plastic breast surgeon and breast MDT lead for Guy's and St. Thomas's. I heard my colleague, Dr. NG, who has presented himself, and I'm grateful he's here together with our MDT coordinator, Ms. Burns, and we anticipate more members of the team in the following sessions. We are working to improve our MDT, the efficiency, restructuring it, and we feel that this program is going to be very helpful. So we're looking forward to the further sessions and collaborating with everyone. Thank you so much, and I'm really sorry for not having the camera on. I don't have access to it via my mobile. I'm really sorry about that. Thank you.
That's no problem at all. It's lovely to meet you, and thank you for coming on to introduce yourself. So it's nice to meet you. So next up, as I said, we've got Ben Lam coming to talk to us about the challenges of MDT improvement. So Ben's done a lot of different work with us on MDT improvement, so we're very, very lucky to have him back with us. Ben, are you on the call?
Yeah, I am. Hi, can you hear me okay?
Yes, we can.
Yeah, lovely. Thanks for inviting me back. I gave this talk last year, so hopefully it wasn't so terrible that I didn't get invited again. I'm going to share my screen and just present from my slide deck here. But it's lovely to see you all, and I think the program is a really great initiative. So I'm very pleased to be participating in that and to meet you today. Just try and start slideshow. Can you all see that?
Yes, we can. Thanks, Ben.
Fantastic. Good. So my disclosures there. So I think this, the benefits of MDT working probably doesn't need a lot of explanation, other than to say that since I started, my interest in MDT working started back in 2009, and over that period, we've seen an increase in the amount of evidence suggesting that working collaboratively in a multidisciplinary team when we're looking after patients with cancer is really the gold standard approach. There's good evidence that it reduces variability in treatments, meaning, if treatments are variable, some are getting substandard treatments, some are getting excellent treatments. So it closes that gap. It improves timeliness to treatment, improves adherence to our guidelines, which are evidence-based, so we know patients are getting better treatments. And there's some studies suggesting that working as an MDT actually improves patient survival compared to, older-fashioned, more linear ways of working. But there are also some indirect benefits, which are perhaps harder to pin down, but MDT seem to be good for us as healthcare professionals, working collaboratively with other people, with our colleagues. We learn from them, and despite the resource that goes into them, many studies suggest they actually present very good value for money in the NHS. And the more we talk to patients about MDTs, the more we realise actually for patients, often they want to know that it's not just one person's view, but maybe getting a second opinion. But when we tell them, you've had the opinion of 10 people, they find that very reassuring. However, as we've heard some colleagues today say already, the complexity is going up, the number of patients is going up, patients are living longer because they're surviving longer from cancer, they're having more tests, they're having, more treatments. So the whole thing is getting busier and more complex. And I think this has been recognised both by the government, Department of Health, by charities, by other organisations, and has been a focus in several key policy documents, saying, look, we really need to focus on complex cases. The current way of working isn't sustainable, and we need to use the tools and the things that are out there that have been validated and that we know can help to improve the way we work. And this is just an example of some of these tools which researchers and clinicians have developed for, first of all, measuring and understanding how your team is working, which then allows you to identify areas for improvement. And these tools cover surveys, they're observational tools, they're frameworks for introducing improvements, for looking at leadership, looking at case complexity, etc. So they exist. So, and then these tools can be used in a number of different ways. So some of them can be used within the MDT meeting, which is the circle on the left, for preparing and selecting cases, help us understand which are complex, which are simple, how do we make sense of that. There are other tools that can be used in the meeting and other initiatives, like there's a very good toolkit for hybrid MDTs. There are checklists that you can use, and then other things that we know are beneficial, like having breaks, having refreshments, the way you set out your room, the way that the leadership functions in the MDT meeting. These are all things that we know work in MDT meetings. And then outside that on the right, you can see that there might be others that you use periodically for self-assessment or for strategic improvement or team building. So they're used in a slightly different way to strengthen your team and make sure you're working in the right direction. And putting these things together, collecting data, learning from what you do, seeing where you can improve, kind of developing a culture of improvement should be fairly straightforward, right? So why are we here? How come, you know, we've got the tools available, we understand the problem, why are we still struggling? Because, you know, we all are, and it's not a problem unique to the people here today. This is something which is a challenge across the world. Well, my colleague Tiana Sukup, who I work closely with, she's an implementation scientist at Imperial College. She's mapped on the NHS England guidance for streamlining onto the Medical Research Council definition of complex intervention. And the problem is that our MDTs are extremely complex. It's a complex intervention in itself. There are lots of moving parts. There are human factors, there are technical things, there's the complexity of our patients and so on. So this is not an easy problem to solve. So I think MDT improvement is challenging. To compound the problem, although the literature on MDTs is growing and MDT improvement is growing, you can see in the bottom left there, the number of publications which contain the word multidisciplinary team, it's growing exponentially. It's not always very useful for your specific type of improvement. So for streamlining, for example, we've done a systematic review where we've reviewed almost 1,000 publications on MDT working, and only 4 of them mention streamlining. So in some areas there is an absence of evidence which makes improvement even more difficult. What's more frustrating is that often when we do studies, when we do find evidence, it will take on average 17 years for that evidence to make it into clinical practice. So teams like yours, teams like mine, who have an interest in MDT improvement, we are really forging ahead. We are generating that data, we are generating you know, that learning, which we need to share with others to kind of close that gap and improve the amount of information, the amount of learning that's available to teams around the country and around the world on how to improve their MDT meetings and how they work together. So I've been asked to talk about, well, what are the challenges with MDT improvement? In preparation for this, I spoke to some of my colleagues, both at Cancer Alliances, clinicians, other people I've worked with, and you can see here, these are some of the reasons people have described that MDT improvement work is challenging, from engagement to job planning to lack of interest, to people being stuck in their ways and not liking to change, you know, trouble with technology. And probably these are things that you've all experienced yourself. So what do we do about it? Well, I've put together a few, what I hope are fairly kind of simple things that I've learned over the years that I've been interested in this. First of all, I think it's really key to get engagement from your team. And the reason from this is that your individual perspective about what the challenges are and therefore what the solutions are is very influenced by your own background and your own understanding of the world. It's a bit like the analogy of blindfolded people finding an elephant, and depending on which bit you grab, you think it's something different. And Dr. Sukup has very nicely demonstrated this when it comes to looking at complexity of cases. What she found was that each professional group within the MDT, when asked what makes a complex case, has a different definition. And so unless we work collaboratively at addressing MDT improvement, we're not going to be able to really address some of the challenges that perhaps other team members feel are other things that need addressing. So I think getting engagement with your team from, as is the nature of multidisciplinary teams with people from different disciplines is a really crucial first step. So when I started as the clinical lead for MDT improvement at the North East London Cancer Alliance, we started the program with an engagement event, and we got people from senior leaders at the trusts and at the Alliance, all the way down to people working on the ground with patients and also some patient representatives. And we actually brainstormed and co-designed our work programs, which I think if you'd asked me to write on a piece of paper, what do I think the priorities are, what should the work streams be, I would have missed most of them. And actually getting other people's opinion, getting people engaged, and also identifying those people who are fellow enthusiasts when it comes to MDT improvement is also really important. I think the second thing is, once you've got that engagement, you've got to keep it. It's got to be sustainable, because any change is hard work. You've got to be in it for the long run. And so it's important to kind of capture that enthusiasm and build a framework which will allow regular review, regular input. And again, in North East London, we've got a MDT improvement steering committee in our Cancer Alliance, and that's made up of, we've got a project manager, we've got clinicians, we've got managers, we've got IT input, so that for each of these areas of improvement we're addressing, we've got the right people guiding and advising us, and we've got accountability and that kind of drive to see things through. Where there are particular areas of interest, like introducing technology or introducing streamlining, we'll set up short-term working groups so that people can put in some more intense effort for a set period of time to deliver a project. And it's also important to keep stakeholders, the broader people with an interest in MDT working and MDT improvement, and the MDTs themselves, keep them informed of what's going on. I think understanding your own MDT is really key, because I think MDT, it's not one size fits all. Each MDT is unique, and we don't actually get the opportunity to go to other people's MDT meetings and understand how they work. So it's easy to be in a kind of silo where we're trying to implement things that maybe other people have done but don't really fit with the way we work. And an example of this is, this is our how our gynae oncology MDT is set up in North East London. So we have 5 local MDTs. They meet each week, then they feed certain cases into the SMDT. If we come up with an intervention or an improvement to fit that structure and then applied it to other cancer types, it probably would fail, because as you can see here, for lower GI, for urology, for breast, they're all set up completely differently. And so their workflows are different, the staff they have are different, the resources they have are different. So I think understanding in pretty fine detail how your workflow works. It will help you to adapt any interventions, any improvements to your own MDT. And if you're from a cancer alliance or a trust, you need to understand the differences and the different ways different MDTs work together. I think when you're starting, it's easy to think, right, there are key things that I want to influence or I want to change. Some of them will be intractable historical problems, and I would say don't bother. Look for the things which are going to be easy to address, where you've got people who are enthusiastic, where everyone's kind of vision is aligned, and it's going to be an low-hanging fruit to make a quick improvement. Because I think that then demonstrates to your team we can improve things, we can make changes, and then you can get the momentum going. And not all problems can be solved by MDT enthusiasts or MDT leads or quality improvement departments. Some problems need intervention from line managers and so on, and perhaps if that's outside your remit, it's not even worth going there. Think about the future, because we've all got a limited time span for our jobs. Our jobs change, other people take over our roles, get new consultants, new nurses, new coordinators coming in. Think about how you're going to educate and train these new team members. And there are training programs that exist. This is one good example. In North East London, we've set up an MDT leadership development program. In East of England, they've got a very good training program for MDT coordinators, and there are others for senior nurses. So think about the longevity of your team. If you've got people who are interested in MDT working or MDT leadership, who perhaps would take on those roles in the future, think about how do you train them up so they can hit the ground running. And then I think this is the final thing: share what you've done, because too often where MDTs are making improvements, they are chipping away, they are making things better. Let us know what you're doing. Let the world know what you're doing. Share your findings so that other people can learn, and you'll save other teams time, and we can all learn from each other. And there are some really good resources out there. The top right picture there is from team at Queen Mary's, University of London, and the North Central London Cancer Alliance, who developed a toolkit for hybrid MDTs, so those that are online and in person. Greater Manchester have done a lot of work on improving their MDT meetings and their MDTs, and they've got some resources available. So share, it's, unless these people share that, we can't learn from them and benefit. And then hopefully we'll be generating information, generating resources that other people can use as well. So I think MDT improvement is a big and challenging issue. And so I think that the only way we'll get through that is to just chip away and tackle one problem at a time, and don't see it as an insurmountable problem, because I think we can improve the way we work together. Thank you.
Great, thank you so much, Ben. I feel like that's a really motivating thing to start with and start of our program. Does anyone have any questions or comments for Ben? No? Well, Ben will be joining us again in December for one of our sessions to talk about MDT leadership, so it won't be the last CC of him. But yeah, thank you so much, Ben.
Thanks very much.
And next up on the agenda, we're going to be talking about the programme aims and outputs, and Robin Cutforth, who I work with, will be presenting that. Over to you, Robin.
Thanks so much, Dua. Hello, everyone. I've had the privilege of meeting some of you as part of the kind of welcome process to the programme. But if we haven't met before, my name's Robin Cutforth. I'm a performance manager in the NHS Cancer Programme, and I'm a member of the team who has developed and is delivering this programme. I'd also like to introduce my colleague Alison Poole, who is Head of Improvement in the elective improvement support team. You'll find Alison and I also often come as a pair. So if you've met one of us, we'll be here throughout the duration of the programme to support you. So I'm just going to talk for a few minutes about the programme itself, what we're aiming to do, some of the structure and what the outputs are going to be. So in terms of aims, our main aim is to support you to work towards those MDT improvements. And we want to do this by providing a structured and supportive environment for you to do that. So the programme itself is self-directed. We aren't going to tell you what to do. We're not going to tell you how to do it. And you'll be planning and leading your own work towards MDT improvements. What we will do is hopefully equip you with any knowledge and confidence that you need to do that, and provide support to facilitate your own change and improvements. And the main output we're looking for really is in the MDT itself. It's that improvement. And I just want to emphasize that improvement can be any scale. As Ben has just pointed out, often it's good to take things step by step and start with something small. So your improvement can be small or large. What we ask is that the improvement itself is something that all your team members, supporting staff and patients will benefit from. And that's either during the duration of the programme, which finishes on the 5th of February, or afterwards. So we're not saying that you necessarily have to make all your improvements over the next 18 weeks. You can plan to do work afterwards. That's absolutely fine. So the structure, as I've just mentioned, we have 18 weeks as part of the programme. So we finish on the 5th of February, and we do have a 2-week break for Christmas and New Year. So we don't have any content. We haven't scheduled any meetings during that time. And during that time, there are 5 learning sessions that we encourage all core team members of the MDT to attend. Now, each of these learning sessions comprises of presentations from MDTs who have already made improvements to their way of working. So they're coming along to share with you what they did and how. And also an action learning set, which is a group activity around a particular challenge with MDT improvement, and then hopefully a potential solution. So we will share these dates again at the end of the meeting, so you have them if you don't already have them in your diary. But just to run through, our first session is on the 23rd of October. At that point, we will be having part 2 of the QI methodology presentation from the team at Great Ormond Street Hospital. Part 1 will be later on this afternoon. And we'll also start talking about MDT streamlining. On Tuesday, the 4th of November, is part 2 of MDT streamlining. Wednesday, the 19th of November, we're going to be talking about inter-provider MDT working. Tuesday, the 2nd of December, we're going to be talking about MDT prep. And Thursday, the 18th of December, we're going to be talking about MDT communication and leadership. So on the 5th of February, we're going to end with a handover event, and all team members are encouraged to attend this. And that's really kind of like a celebration of what you've done and what you've learnt during the programme and preparing you for the future. Now, the rest of that 18 weeks in between learning sessions, you can choose to spend that time however you wish. So we have recommended dedicating collectively around half a day a week to doing your improvement work. And that's because the amount of time you can commit to a project often impacts the outcome. However, that's just a suggestion. You have the freedom to decide and dedicate whatever time you can to that work. So as I mentioned, the handover event, it's going to be a bit of a celebration. And by that point, the 5th of February, we expect all teams to have either implemented or planned a change in how their MDT operates, repeated the self-assessment exercise that you've hopefully all already done once before, and that should help you review the impact of the change or learning that you've got from the programme, and also produce a poster for that handover event. And we're going to ask you to present it during the event. We have a template that you could use, so you don't have to do that from scratch. And that poster should detail what improvement you identified, what have you achieved or planned, and the impact of that during the programme. One really important aspect of the support we offer during the programme is coaching. So every team has a coach from NHS England assigned to you. You have also been asked to designate a project lead for your team. That project lead will meet with the NHS England coach about every 2 weeks throughout the programme on Teams. And the role of that coach is to support you to work towards that change. So if anyone's ever had coaching before, what they do is they will ask open and challenging questions of you to hopefully prompt some action, some reflection, and to help you identify solutions. So again, their role isn't to tell you what to do, how to do it, or offer advice. And their role isn't to be an expert in MDTs. Their role is more to be a kind of sounding board for your ideas and your problems and to support you through them. So please do use them to your full advantage. You can take notes during them. You can share the details of those meetings with the members of your team. If you can't make a session, please contact your coach directly. The first session has already been scheduled in October. Hopefully, most, if not all of you, have now got that in your diary already, and subsequent sessions will be organised between the coach and the project lead. Just to mention as well, so obviously they will be focused on coaching. If anyone at any point would favour some mentoring input, so for example, if you've come across a challenge and coaching hasn't helped you reach a clear solution for that, you'd like some direct advice on what to do, please contact us because we can offer that separately to the coaching relationship. We will also offer you some quality improvement support. So later on this afternoon, you will meet Caitlin and Nuanthi from Great Ormond Street Hospital. Every project lead will also have a one-off session with them in November. Your NHSE coach will join that as well. So it'll be a meeting between the three of you. It'll be a 30-minute session and it will focus in on your aims as an MDT, so what you want to improve, and help you to prepare to do that using QI methodology. And you can use that session to ask any questions you have about quality improvement or work through any challenges you might have with planning or identifying your aim. And project leads will all receive an Outlook meeting invite for that session shortly. In terms of additional support throughout the programme, so we have a workspace on Future NHS. You've all been invited to it. On that workspace will be recordings of all the learning sessions. So if you don't manage to attend one, you can always catch up with a recording afterwards. We'll also share some programme resources there as well. We also encourage you to engage with your peers throughout the programme. So there will be the opportunity to do that during the learning sessions, particularly the action learning sets. You should also have identified some senior leadership or exec support within your trust. So if you are coming up to major barriers, please do keep them updated on your progress and escalate with them. And also all members of the team are here at any time that you need. That's our email address on the slide, and we will share it in the chat as well. And there is your NHS England coach. Now, Ben has already mentioned some of these in his presentation, but there are some documents of guidance and proposals out there which may support your improvement work. I've put the links to some of them here, and we'll put them on the Futures workspace as well. So there's that NHS England streamlining guidance, which is aimed at cancer alliances, but hopefully can be used by trusts as well. The Royal Colleges recently, I think last month, published a joint proposal on pathways and decision making. There is that virtual and hybrid MDT toolkit that Ben mentioned. And there is also a piece of guidance called the Characteristics of Effective MDT, which I think is over 10 years old now, but can still be of use to teams. I would also encourage you to check out the website of your local Cancer Alliance because they will probably have a lot more resources on there for you. And something that isn't in this list, because it hasn't been published yet, is also the impending National Plan for Cancer, which we are expecting to be published in November. And we do anticipate that there will be content in there regarding MDT meetings. So when that is published, we will have a look at it and let you know if there's anything in there that can also support you. Okay, I think I've done enough talking for now. Does anyone have any questions on anything I was just talked about? You know we're here at any time. you'll feel free to use our email address and email us with any queries you have at any point during the programme. Thank you very much, everyone.
Great, thank you so much, Robin. And yes, we do have our email address in the chat. So if you also need invites to the learning sessions, please do email us as well. And some of your coaches are actually on the call as well, so you'll get to see them there. But yeah, thank you, Robin. And next up, we have Nuwanthi and Caitlin, who are from Great Ormond Street Hospital, who are going to talk to us about designing a successful quality improvement project.
Thank you so much, Dua, and good afternoon, everyone. It's really fantastic to be here with you today. I am just looking for my slides, so please just bear with me for one moment while I bring those up. Nuwanthi, do you want to try bringing them up on your side?
Yeah, can do.
Do you have are you able to?
Yep, I'm going to give it a try.
Thanks.
Coming up now.
Thank you.
Slowly. Think you can see that?
Yes.
Yes. Perfect. Fantastic. Thank you very much, Nuwanthi, and apologies for that slight delay there. But really, it's fantastic to be here with you this afternoon, and we're really looking forward to getting to know you all. And so welcome to our Quality Improvement Part 1, Designing a Successful Quality Improvement Project session. And my name's Caitlin, and I'll be guiding you through the first part of today's 20-minute session. And after that, I'll hand over to my colleague Nuwanthi, who will take you through the rest. And today's session is designed to give you some practical tools and tips to get your project started. We'll also give you some very rapid foundational knowledge of quality improvement and a framework to guide you through the project journey. And as we've heard before, Robin's just talked through it really nicely, but we'll be seeing you again for our second QI teaching session on the 23rd of October. And we've also got a one-off, one-to-one mentorship session with every project team to ensure that we can tailor our advice and guidance to your needs and your chosen improvement work. So yes, as I said, we're really looking forward to getting to know you and to working with you all. But before we dive into the session, here's just a very quick introduction to the team. So I'm Caitlin, and alongside me is Nuwanthi, and we are quality improvement coaches from Great Ormond Street Hospital for Children, based in London. And we're really passionate about improvement in healthcare. And Nuwanthi and I also have a particular interest in QI training. And with that, we've supported other national cancer collaboratives over the past 3 years, which we really enjoy. But our role in this collaborative is to support you in understanding some of the basics of quality improvement and how to apply them practically to your own cancer MDT projects. So let's start with a really simple definition of quality improvement. This is the definition from the Health Foundation, and we think it best encapsulates the main elements of QI, quality improvement. It says that quality improvement is about giving the people closest to issues affecting care quality, so like all of you, the time, permission, skills, and resources to solve them. The second part is that it's a structured approach to solving problems using specific methods and tools, aiming for a measurable improvement. So to summarise, quality improvement gives frontline staff the tools to work together more effectively, trying to turn shared frustrations into measurable improvements in care delivery. And we also know that it helps ensure that every patient benefits from safe, more efficient care. The model for improvement is a widely used quality improvement framework in healthcare, and it's a simple yet powerful framework for realising improvements. And it's the framework we're going to use in this collaborative. And it asks 3 questions, so it's really nice and simple. What is it that we're trying to accomplish? This is our aim. How will we know a change is an improvement? These are our measures. And what change can we make that will result in improvement? These are our ideas. Then we use the plan, do, study, act cycle to test changes in real settings. So for your MDT improvement projects, this will mean starting small, testing ideas and learning as you go. And Ben's already mentioned that around sort of starting small and starting with low-hanging fruit. So we'll definitely be reiterating those messages too. And today we're going to cover just the first two questions in this framework. So we're going to cover aim and measures, and our session later in October is going to cover the third question, and we'll also talk around some tips for sustaining your improvements for that longevity. So now that we've established what we mean by quality improvement and the framework that we're using, here are the aims of today's session. So by the end of this session, you should be able to write a clear problem statement, identify your stakeholders, consider measures for your project, and write a SMART aim. So these are the first building blocks for your own each of your individual cancer MDT improvement projects. So our first aim, to write a problem statement. We'll talk you through that now. With any improvement project, firstly, we need to establish what we're trying to improve. And often this can come in the form of an idea or a solution or how to solve the problem. But what we recommend is actually taking a pause and instead delve deeper into the problem by asking yourself some questions. And these are just some ideas of questions that you could ask yourself. How do I know that I have a problem? What am I hearing and observing? What is the data telling me? Or self-assessments. I think there might be some self-assessment tools that you could use. Who is affected and what are they experiencing? And importantly, who do you need to involve? And these are some helpful first questions to get you started to understand the problem. And Nuanthi and I absolutely love this slide. We use it in every level of QI that we teach. We think it demonstrates really well the pitfalls of jumping straight to solutions, which is, of course, completely human nature. We all do it. We're really taught to bring solutions to problems, aren't we? But when we jump to solutions, what happens is we risk missing the real problem, and we can miss opportunities that are listed here. So brainstorming as a team, understanding your problem, miss our data and understanding what that might mean, co-producing with patients and service users, understanding different options, and working with a range of stakeholders. So taking the time to understand the issue, involving your colleagues who are within your MDTs, and using data to guide your decisions, it's going to really help to make your solutions more effective and sustainable. So this brings it to the problem statement. This brings us to the problem statement itself. So after you've asked yourself those questions, you've involved the right colleagues, you've understood your data and avoided jumping to solutions, we're ready to create our problem statement. The problem statements are really helpful in defining a clear scope or area for improvement. So it makes sure you don't take on too much. You can approach a problem statement as a working definition as well. You may uncover more context and evidence as you move through the stages of your project, so you can always come back and add them to your problem statement. It's fine to update it as you learn more. So the elements of a good problem statement are here on the slide. It's concise, only 1 to 2 sentences. It doesn't refer to how you'll solve it, and it's factual and supported by data. And we've just got quite a basic example here just to prove the point. It may not necessarily be completely relevant to MDT improvement projects. But here it is. So in our London-based lung cancer clinic, several complaints were received recently from patients who had been lost to follow-up. An audit revealed that 37 patients had not been offered an appointment in line with their treatment plan last year. So that's just a nice, simple example of the type of thing that we would look for in a good problem statement. And to build on our problem statement, to help kind of continue to build that insight, there are 3 charts that may help you further understand the problem. And they are Pareto charts, run charts, and process maps or flow charts. So just talking very briefly through each of them, Pareto charts tell us what the problem is. It narrows down the most common issue from a set of data. Run charts present data over time, and they can show us when the problem is occurring by clearly visualizing trends and patterns. And finally, flow charts or process maps tell us where in the process the problem is occurring. And we do that by mapping out all of the steps in a process in its kind of true state, its current state. And these tools make patterns and priorities clearer. I think what's fair to say, we'd anticipate that maybe mapping your MDT processes could be a really useful, most useful of these charts. And actually, Ben mentioned mapping out the way that MDTs work in his talk as well. So I think that is potentially maybe a tool that you might want to think about using once you start your project work. Okay, we're on to our second aim of our brief 20-minute session now, which is to identify your stakeholders. And we're going to answer this question through a chat bomb. So for those who've never done a chat bomb before or never heard of it, that's fine. I'm going to talk you through how it works now. So what I'd like you to do is open up the chat and type out your response, but please don't press enter or send just yet. Hold on till I say that you can, and then hit send or enter. So the idea is that we're going to see a whole host of all of your original ideas shared at the same time, a lovely sort of waterfall of responses. So we're going to do this together now. I'm going to give you just 20 seconds to type in a response to the question that we have on the slide here. What is a stakeholder? But remember, please don't press enter or send until I say so. So 20 seconds has started. Okay, that's 20 seconds. So everyone, can you please hit send? Fantastic. That's exactly what we like to see, isn't it, Nwati? So lots of ideas all coming in at the same time. And you can see there's some really similar things all involved in the process. People who are affected, impacted are some other words that I keep seeing pops up. Person who has a vested interest in any potential change. A person with key, contributes, influence as well. Anything else you've spotted, Nwati?
Impacted,
yeah. Everyone in the MDM or the MDT, all members of the MDT, patients, carers. Fantastic. So that's great. Yeah, that's brilliant. So we quite like using chat bombs, so you'll see these come up again in our future sessions, and again I think this afternoon. So that's perfect, and your definitions match really perfectly to the one that we like to use. We think that there are three key aspects to defining a stakeholder, and they are people who are influential to the project, could be impacted by it, or could be involved in it. And sometimes stakeholders aren't obvious or visible in chosen areas for improvement. So this next tool now is, I think, going to help you think a little bit more broadly. So I'm taking you over to Nwati now. Over to you, Nwati.
Thank you, Caitlin. This is really a nice place to get into this now. So just as you said, Caitlin, this is what we can see on the screen is a simple way how you can start thinking about your stakeholders. It's a mind map. We think this is something that's important to consider quite early on, even now, when you're identifying or when you're thinking about your problem. But also remember that it can evolve over the time frame of your project as well. You can see here, I have used the same problem that Caitlin mentioned before. So it's just a very rough example. You can see that we have divided it into the external and internal stakeholders. The point here is that you're not expected to engage with everyone at the same level here, but this is for you to consider your stakeholders so you don't forget any of those key individuals. So you can start making a plan about those engagement. Going back to the points that Ben talked about as well. It's all those different points of view that's really important to capture as you go on. So while we have now just talked about a little bit around the problem statement, I want us to now get better at really understanding our problem and delve deeper into it. And we said that quality improvement is always guided by data so that we can actually make meaningful change. We don't do change for the sake of change. Let's look at that second question of the model for improvement that Caitlin introduced. And look at setting up some measures for your project. We will not go into great detail as this presentation will follow by a really useful presentation on data, I think. So that's coming up.
To understand why data is important, let's first touch on what we mean by data for improvement, because data can be used for many different things. Data for improvement is valuable information collected to help decision making, provide that insight, and it guides your improvement work. We need evidence to show improvement, and this is where data comes in. Broadly, there's two types of data for improvement. You can see here on the screen the quantitative aspect, which comes through from numbers, the counts, for example, the quantitative measures that's very common in the NHS that we come across quite often, like around wait times, response rates, referral rates, and things like that. On the qualitative side, a lot of people forget that when it comes to data, that there's a qualitative aspect equally as important as well. The non-numerical data or the information comes through from descriptions, observations, feedback, and you can collect these from surveys, your interviews, your patient stories, focus groups, for example, as well. So when you think about data for improvement, think about both of these aspects. We use this data broadly in two different ways. One is to diagnose the problem, just like how you clinicians do when you try to understand your patient's pain levels and things like that. You go and ask how much is the pain level, for example, but also to show that you're making an improvement. So diagnose the problem to show an improvement. So those are the two different ways. The diagnostic side really helps you convert that hunch, the general feeling, into a well-articulated problem statement. And Caitlin already talked about this. So essentially, this is data that's been used to understand the opportunity for improvement and where exactly to focus our efforts on. And here's an example from our trust that we like to use. So we are using bar charts here to understand what times the most number of clinical emergency calls happen during the day, and the times when the most number of unplanned ICU admissions happen. This is from a project that we are working on to improve processes around acute deterioration. So when you look at something like this, we are able to drill down to those specific times that we want to understand what is really going on, for example. So that's just use of diagnosing a problem. When it comes to data for improvement on the showing your improvement, we use three main measures that is really useful. We use outcome, process, and balancing measures to show that our change is actually leading to an improvement. So what you can see on the screen, there's a description and an example. So I'll take outcome measures. This is the overall aim of the project. From our previous example, essentially, this is a reduction of patients lost to follow-up. And you usually have one outcome measure for your project. The process measures are tied to your change idea. So imagine as part of your trying to reduce patients lost to follow-up, the change intervention that you are trying to do is to introduce a new electronic tracking system. And the process measure here is, it's really useful to keep an eye to see how well we are adding our patients to this tracking system. Because in theory, if they all get added on well to the system, our numbers of patients getting lost to follow-up will reduce. So process measures are really useful in showing that you're going on the right direction. There is a third type of measure also. These are balancing measures, which keeps an eye on the unintended consequences. I think Ben again talked about this as well. It's not easy to make change in one place and it can get affected somewhere else. So we want to make sure we are not affecting other areas of our work negatively. So I've used this example of increasing costs here as a thing that we want to keep an eye on. So I hope this makes sense. But as Caitlin said, during our conversations, we can get more into this detail as well. So now that we've really understood our problem, engaged with our stakeholders, and considered our measures, this is the point that it's really useful to come up with a project aim, a statement, and not just any aim, a SMART aim. So that's what we'll talk about. As Caitlin said, we like our chat bombs. Let's do a chat bomb again, and I'll give you 20 seconds for this. what does a SMART aim mean? What does the SMART of a SMART aim mean? And if you can go back to your chat and don't press send till I say so, your time starts now for 20 seconds. What does SMART in the SMART mean? And press send. Again, I think we are seeing quite a lot of similar themes that's coming up as well. I'll get on to the point here. I think it's not a topic that is unfamiliar to many of you.
Judging by the chat, seems very familiar, yeah.
Very familiar. So, because I think we use it quite a lot outside of improvement work as well. So what I wanted to just do is a quick summary of it. When writing your SMART aim for your project, it's a statement, it's a sentence. So let's try to be as specific as possible. The where, who, what are you trying to do has to be part of it. It has to be measurable. So include what you have identified from your diagnostics and where you want to go with it. Is it achievable, or have you set the bar too high there? Is it realistic with your current commitments? Or, for example, in the middle of a pandemic, say, is this the focus? Is it relevant? Does it align with your team's objectives? And is there consensus, or are you doing something completely different from what everybody else is looking to do? And of course, like any project, it should have an end date too. So this is what it means to have a SMART aim. So as we continue with our example, here we have converted our problem and our diagnostic data now into a SMART aim. Let me just bring that up for you. So reduce the percentage of patients who are lost to follow-up in the lung cancer clinic by 50% by March 2026. So that's what our provisional, what Caitlin and I came up with, SMART aims looks like. So we have played with the words here a little bit. You can say reduce it to 0 if it's achievable. But in some projects, achieving 0 is not possible. So rather than saying we aim to reduce patients lost to follow-up from 37 to 18, we have said 50% reduction, which sounds more engaging. So you can also see we have used very specifically saying lung cancer clinic, because that's the scope that we can work on at this moment. And that's what our diagnostic data had said. So that's another point to take away as well. What you don't have in your SMART aim is your change idea. So be careful of that as well. So all this time you're still writing around your problem statement. We'll leave this with you and the slides will be shared. So this is a really useful template to follow when you're writing your SMART aim as well. So you can say to improve, reduce, increase kind of thing, X, which is our loss to follow-up numbers, and by the percentage, which is 50% for the target group being the lung cancer clinic or the whole of the trust, whichever, and by the end date. So this really helps us to do that as well. A little exercise again. I think all of you can see the React button on top of the ribbon on next to the leave share and all that, so on the very top. If you can use those React buttons and tell me which one is the SMART aim from here. So either use a thumbs up or a clap or a smiley face or a heart to tell me which one reads as the best SMART aim from what's shown on the screen. Seeing a lot of claps. This is great.
Great.
Yes. Thank you. So
Got
yes,
an experienced group.
yes, to reduce missed appointments by 10% in our outpatients department by December 2026 is
Fantastic.
the SMART aim. The first and the third one either are too broad, it's not specific, or are not achievable. You can see clearly there somebody's trying to reduce missed appointments by 2025 in November, that's next month. The last one, it's not even a an improvement SMART aim. It is an intervention It's a change idea itself. So be really careful when you're writing your improvement SMART aim that you do not include your change idea in that. Right, Caitlin, that is the end of our session today. We covered how to get started on your QI project. We will continue on our journey again later this month. So in the meantime, it is a good idea to start looking at your diagnostics. It's okay to spend time on it. It's like your good foundation. We will cover the change ideas in the next session, along with how to generate them, test them, and how to make them stick. So thank you very much for your time.
Thanks, everyone. If there are any questions, we're happy to take them as well.
Great, thank you guys so much. Any questions, Andrea? Oh, Andrea, did you have a question or?
Sorry, no.
No. Anyone else have any questions? Oh, I am a very big fan of the chat bomb, and I feel like we should start using that ourselves. So thanks for sharing that. And yeah, it's really, really great that you guys are going to be back to deliver on the session, but you're also going to be doing some coaching. So yeah, looking forward to seeing how you get on with everyone then. So thank you so much.
Thank you.
Thank you.
And last but not least on the agenda, we've got Alex Graham coming along to talk to us about evaluation.
Thanks, Dua. Hi, everybody. Lovely to see you all on this wet and wild Friday afternoon. It's absolutely miserable here in Nottingham, so I don't think it's going to be much different around the rest of the country. So hopefully a bit brighter over the weekend. But I'll stop going on about the weather, introduce myself. So yeah, as Dua said, thank you. So I'm Alex Graham and I'm Research and Evaluation Manager, and I sit within the Operational Improvement Group. So I provide evaluation and research support to emergency care improvement, elective, mental health and community. But I'm here to talk to you today and give you a really, really brief kind of whistle-stop tour about evaluating an improvement project. So hopefully that's helpful. And just to say from the offset, any sort of support that anyone requires with evaluation or any questions you have after this, always happy to receive those and, you know, give any kind of advice and guidance in future. So I'll share my screen, mindful of time as well. I'm trying my best to keep to time, guys, but yeah, I won't keep you any later than necessary. So I'll just share my screen. Here we go, and there we go. So hopefully you can all see the first slide there that says what is evaluation at the very top. If nobody says, yeah.
We can see them, but do you want to zoom in to them?
Can you see my notes on there as well?
Yeah.
Yeah, okay. Bear with me then. Let me just stop sharing 1 second. Give me 2 ticks. There we go. Sorry, guys. Tech issues straight away. That's what we don't want.
That's okay. I can never share my screen because it just crashes every time. So they've got me hosting and not presenting my slides.
Yeah, I know, and I give myself a good few minutes just to, you know, test this beforehand and failed at the first hurdle. Bear with me. Let's move it over there. I'll move you over to my big screen. There we go. No, it's still not having it. Oh dear.
Alex, I think I have your slides if they're the same as last time.
Yeah,
if you want me to present them for you.
Is that all right, Robin? I'm sorry to be a bit of a pain. Yeah, I'm trying to operate duplicate screens. You know, we should be all right with this, and you know, but I've fallen at the first hurdle. Apologies, everybody, for the delay.
Thanks, Robin.
Thanks, Robin. Appreciate your help. Oh, thanks, Robin. Usually helpful. Did you want? Yeah, great. So the first slide, what is evaluation? So I thought I'd just put a little introductory slides in here around defining evaluation. So generally, any evaluation is looking at measurement and looking at a planned investigation of an intended change or intervention. So kind of actively wanting to change something and investigating the impact and effect that that's had. I think impact is, you know, especially where we are at the moment in the healthcare system, the impact and the difference that we kind of make in all of our projects is a massively helpful and important component to understand and kind of know, so we can kind of learn from that in future. And that therefore brings us on to why we do it. So it brings the structure, transparency, and it gives helpful weight to any claims we might make about the change that we've been trying to achieve. It's much better generally if it's done by somebody who's not been involved in the project in the design and delivery phases of the improvement project itself. Generally, we wouldn't want to mark our own homework, so having little or no bias at all would be really helpful when planning or doing any evaluation. But naturally, sometimes this isn't possible. So generally, we say any feedback is good feedback. So any method of evaluation done by anybody is helpful for any improvement project. So generally, I think, as a rule, don't be afraid of the word evaluation. It can sound complex, but it can be small or large and applied to any project at all. And it may be as simple as an end of program survey, feedback form, or it can be a full impact evaluation from kind of beginning to end, where we're collecting a lot of data throughout the duration of the program with cost associations and things like that. It's good practice to learn from outputs, outcomes and impact of having actually done something, and as projects get bigger, they'll naturally need more resources and specialist people conducting said evaluation, but it doesn't always need kind of an expert for an evaluation. We don't always have to commission somebody out, dependent on the resource and the complexity of the project. Generally, anyone can do it. Often a question that comes up is understanding, especially at the moment in the nature of the systems we work in, is understanding kind of economic impact of changes. But I'll just say first off, I guess this is something that's really, really difficult to understand in terms of understanding return on investment and financial cost associations in terms of what we initially get back from a financial perspective of inputs from a project to an improvement project. This can require specialist methods and can be costly. So, but generally this isn't needed. A lot of our evaluations can be more process driven and theoretical, and generally the resource needs to be proportionate to what it is that we're actually doing in terms of the scale of the intervention, and also indeed appropriate to the topic area. Can I have the next slide, Robin? I'm really sorry, I'm going to have to ask you to move on, aren't I, after every slide now? But thank you again. So different components of the intervention, and this is the way I'll frame the next few slides, so I won't spend too long here, but I'll look at kind of scoping and project initiation of an evaluation project, designing and feasibility testing, data connection and analysis, looking at kind of field work and how we might collect data throughout the improvement project itself, and then most importantly sharing what we've learned as a result of what we've evaluated, so reporting and dissemination. Can I have the next slide please, Robin? Thank you. So what we've got on the screen at the moment is a logic model. Don't know how familiar colleagues in the room are with logic models, but I think one of the most important things that for an evaluation, you know, what we're first off learning around is evaluating at the very beginning and thinking about how we might measure what it is that we're going to do and what it is that we want to achieve at the very beginning, at the very onset. And a logic model is essentially, it can be a project management tool as well as an evaluation plan. And that's essentially how I'm trying to put this across as a logic model. So it's a plan for evaluation for the whole improvement project. And we do this at the very beginning of the improvement project in line with any kind of project management materials or documentation that we might use when setting up that project. And so this is an example of so we did a rapid improvement offer for the emergency improvement team just coming up to a year ago now, last winter. And this, so I'll just talk you through the model itself, but it's essentially an overview of the different components of the offer itself. So at the very top there, we've got the situation, which is essentially the problem that the rapid improvement offer or the project improvement program was set up to support or enable, support solving or support creating solutions for. So we've got the rapid improvement offer was set up for intensive improvement support to tier 1 sites in terms of the tiering for emergency care and urgent care in the country, in response to rising concerns in patient safety across 11 acute hospital sites. And the way in which they were going to be measured and the success measures were those 3 things there around percentage of ambulance handover delays, performance against 4-hour standards, and performance against 12-hour standards. So that was kind of the problem and the kind of the area of which we were looking to improve from an emergency improvement support team's perspective. And I'll jump straight to the outcomes section of that logic model, because those outcomes there should essentially mirror some of the problems that we've stated in that situation section. So in order to solve things like issues with percentage of handover delays and performance against 4 hours, what we're looking to do is things like reduce activity in ED, reduce length of stay in ED, reduce ED admissions and improve flow, decompression of ED, things like that. So generally what I'm getting at is all of the sort of issues that we kind of state in that situation section, they should be ultimately mirrored in those outcomes. So, you know, one should speak to the other and they should work in tandem with each other. And then moving slightly left onto the model. So the inputs on the far left-hand side are essentially all of the things that we would kind of associate of having a cost or a little bit of something that's a tangible element that we invest to the improvement project. So things like NHS England improvement expertise, time in which the colleagues are going to be provided in terms of their, you know, their kind of salaried individuals. So it's a cost associated that we're investing into that project. Things like data diagnostics, financial investments such as time and travel. And then the way in which we've separated this logic model, and not all models will look exactly like this, they're all definitely bespoke, dependent on the improvement project that you're working on. We've separated these models in terms of work streams. So in the rapid improvement offer, we had all these work streams that are listed in that activities section, and we separated those in which they were things like streaming, length of stay, and we specified the deliverables that were associated to those activities and then mapped those outcomes with those deliverables. And the deliverables are kind of the outputs and products of what we do. So the action we take as a result of the overarching activity, so such as streaming. So things like improving utilisation of UTC and direct access pathways. And what we're saying is, and we, you know, in the previous presentation, we were talking about SMART goals. So things like reducing activity in ED, those things should be measurable, and that's what you should then sort of map your kind of SMART objective around, that kind of outcome there. And then towards the right hand side of that, what we've got are goals, benefits and national objectives, which is essentially kind of the ultimate point of our work. So those 4 things that we've been asked to move as a result of the rapid improvement offer. And I think what's really important to kind of just state here is kind of there's an accountability threshold that isn't necessarily stated on that model there, but sort of between the outcomes and those ultimate objectives. What we're saying is our improvement activity may contribute some of those goals and benefits and objectives and the ultimate point of our work, but what we're held accountable for actually are those outcomes there, which are sort of more specific, again, the SMART objectives, more specific outcomes that we can directly map to our deliverables and activities. And hopefully we can see that by doing this, where we're stating our outcomes, we're ultimately confirming that those are the things that we're going to be collecting data towards to then measure ourselves against whether or not we're achieving what we're saying that we are going to achieve. And that's essentially your evaluation plan from the very beginning. So really important to really think about that evaluation at the very beginning, so we can continue to collect data throughout the duration of the rapid improvement offer improvement project. So then at the very end, you've got a lot of data to then work through. So then data analysis is super easy. We're not getting to the end of an improvement program thinking, oh, I need to go and collect all my data now. You know, let's do a survey. If it's already there, you know, fantastic. Can we move to the next slide, please? Thank you. So I'll just rattle through these next 3 slides really quickly, really mindful of time. So The design of an evaluation, super important, but I will keep linking back to that logic model. So this visual here is a visual taken from the Magenta book, which is essentially civil service guidance, and it's got an overview of all different design aspects of an evaluation, and it goes up in complexity from kind of developmental process evaluation to value for money. And I'm not sure if anyone's heard of, I'm sure you have, the Kirkpatrick levels, which are the different levels of complexity in terms of evaluation. So we've got things like a reaction evaluation and a learning evaluation, and that's things like, did the learners enjoy the training? I think your slides have just gone, Robin.
They have. Give me just 1 second to get them
Sorry.
Don't worry, I think
I'll just keep talking, it's fine, I'm just to make you aware.
Keep talking, yeah.
No, you're fine. If I had got the slides on there myself, that this wouldn't, hopefully, but I'm appreciating your time there. So the Kirkpatrick levels I was just mentioning there a second ago. So in terms of the reaction level and the learning level, so these can be mapped similarly to the developmental and process evaluation around, did the learners enjoy the training, and was the training kind of worth the time invested, and whether or not the learners kind of acquired the intended knowledge, expertise, skills and confidence from the training. So quite low level feedback there, but still super important, and may well be something that is mapped initially to kind of an improvement project and done repeatedly throughout the duration of the time, whether or not that's their kind of modules or different sections of a project. And then the other two levels are behaviours. So did the learner's behaviour change as a result of their learning, and therefore was it applied to role, and therefore results, so more of an impact focus. So it focuses on those measurable outcomes around, did the training have measurable impacts on performance? And these are just some examples in there on the slide what I've popped in that's specific to kind of this cancer MDT programme. So hopefully that's a little bit more relatable for the team. And if we can just skip to the data collection slide, Robin, which isn't the next slide, it's the slide after. Thank you, that's really helpful. So in terms of data collection and analysis, so hopefully if we've initially mapped a logic model at the very beginning and we've kind of attributed data to some of the outcomes that we've already outlaid in that logic model, we've already got a load of wealth of data at the end of our programme to kind of review and monitor. And if we've been reporting throughout the programme, then even better. And as it was mentioned in the previous presentation, qualitative and quantitative both equally as important to each other. The focus does tend to be on quantitative, especially in the world I sit in, which is emergency care. But qualitative is super important. Things like culture, behaviours, leadership, the majority of the time those things are mostly measured through things like qualitative data and therefore analysis. So when we know that leadership and behaviour doesn't necessarily, data, numerical data will change in tandem with things like behaviour, culture and leadership. So really important to take both into account. But practical requirements for things like data collection analysis, things like ethics, really important to understand whether or not we need to gain ethical approval for any kind of data collection and analysis. Information governance, so where it is that you're collecting the data from, do we need to seek any approval? Testing the data collection or access, agreement with sites in terms of data sharing agreements, and then in quality assurance. So can we be assured that this is reliable and valid data that it is that we're using to inform the success and evaluate the project itself? And then the final slide is looking at kind of reporting and dissemination. If we just move on to the next slide, Robin, thank you. So generally, really important, and I guess if we are evaluating a piece of work, really important to use what it is that we're kind of learning through any kind of evaluation, just to kind of hold ourselves accountable to share what it is that we've learned and share with relevant stakeholders. Again, stakeholders were mentioned in the previous presentation. So have we met the expectations of those that have commissioned us to deliver said improvement project? And what have we learned as a result? And therefore, what do we need to change for future iterations of said project to improve? How can we, better ourselves as teachers or learners for future programmes? And that should therefore be done in the best format and then in the right to the right decision makers. And I've just popped a little quote on there from the DHSC evaluation strategy. So to ensure the department's approach to evaluation is transparent, we'll continue to publish evaluation activity. So I would encourage any kind of evaluation reports to be shared and published so others can learn, even if they've not necessarily been a part of said project. But really helpful to be transparent with what it is that we find. And I won't necessarily go through the next couple of slides, but I imagine these slides will be shared for you guys for future. And so the next 2 slides just look at a checklist for establishing evaluation. And I find this really helpful, just really going through and kind of understanding the things that you might not necessarily think about when looking to evaluate your improvement project. Things like leadership support, hugely important. And that resources are assigned to undertake the evaluation. I think that can be forgotten about. It can be quite resource heavy, looking at evaluation and how we might collect all of the data that we need to kind of understand what difference we've made as a result of an improvement project. So really factor that in at the very beginning. And the final slide, there's a few links in there if anyone is interested and wants to do a little bit more reading. And as I said at the beginning, any further questions or any support on this, if you need anything to support with any kind of evaluation of your improvement project, please do reach out and I can pop my email in the chat. But I'll stop talking. I know I've gone a little bit over time. Sorry, guys, and apologies for the tech issues at the beginning. Thanks, guys.
Thank you so much, Alex. I really appreciate it. I know we're running a bit over. Does anyone have any questions about evaluation or about anything we've said actually today?
I'm never sure if that's a good sign or not.
Yeah. Anthony?
Just to say thank you so very much for your time this afternoon. It's been really informative and really enjoyed it. Thank you.
Oh, thank you so much. Well, yeah, I hope everyone's enjoyed it and yeah, found it helpful. Thank you. Well, we do have Worry More Dress in the chat. Oh, actually, before we go, here we have our schedule of events that are going to take place. So obviously we've just done the welcome event. We're going to have 5 more sessions and then the handover event. And if you don't have those invites in your diary, then please do contact us. Our email address is in the chat box. We'll put it in again. But if you have any questions in the meantime, feel free to get in touch with via our email address. So you can email myself or Robin or Alison or anyone else. We can pop our email addresses there as well. But yeah, thank you so much to all of our presenters and to all of you for being here today. It's been really, really nice to meet you. I'm really looking forward to the next few months with you and I hope that we can make lots of improvements together. But yeah, thank you so much, everyone.
Thank you. Bye-bye now.
Take care.
Thank you.
Bye.
Bye. Bye.